And our conversation tonight is brought to you by The Sun, sponsored by Kaiser Permanente. Our great healthcare writer, John Ingold, is also with us tonight to help field questions and keep us from going too far off the rails. We have, hopefully later, we'll have live Spanish interpretation on screen as well. We'll let you know when that's available. Everyone who needs healthcare or provides healthcare has been living through extraordinary times. For a while there, a doctor's visit completely disappeared from possibilities. More than half of medical visits were taking place by video during the pandemic. Meanwhile, Apple alone has sold 34 million smartwatches last year, and they want that to become an important part of your health story. Information and misinformation on healthcare are exploding online. And a long overdue push for equity in every aspect of daily life is asking us to make sure we are providing everyone access to the healthcare they need. Where does that leave all of us as patients? Where does that leave our health system as it scrambles to keep up? We'll start with some questions about where technology and COVID have brought us in Colorado, and then we'll add in reader questions as we get them. Please add your questions to the Q&A button at the bottom of your screen, and we'll try to get as many of them as possible tonight. We're fortunate to have our conversation tonight led by a great panel that includes Dr. Autumn Orser, Senior Vice President at Peak Vista Community Health Centers, Colorado Springs, taking care of nearly 100,000 patients in El Paso County and then eastward out onto the plains. Sharif Abdelhamid, Manager of Patient Experience for Denver Health, which of course is the city's safety net hospital, and also a large network of community clinics and a health plan, serving hundreds of thousands of people every day in the Denver metro area. And Dr. Jeff Krawcek, Executive Medical Director of the Colorado Permanente Medical Group, which is a doctor's group for Kaiser Permanente. That's a medical plan that serves more than 600,000 Coloradans throughout much of the state. To our panel, welcome. And I'd like to ask Dr. Krawcek first. Before COVID came along, what would you have said were the biggest changes in the way that you were treating patients, whether it was from new technology, new ways of seeing people through online methods, or wearable or portable monitoring devices? And you've also said that COVID then pushed that ahead 20 years, Jeff. So tell us a little bit about where you were and how quickly it changed during COVID.
Yeah, thanks, Michael. So, we were starting to do some of the wearables and some of the Bluetooth enabled blood pressure monitoring at home, diabetes monitoring, some of those things, and also trying to drive more things like video visits. And I'll tell you, it was sort of hard to get our physicians to really buy into the video visits at first, and our patients as well. I think for generations, we've been used to going to the doctor's office in person. And so that mindset shift, frankly, before COVID was tough for some people. One of the innovations that we had done before COVID was chat with a doc, where you can get on and chat on the computer with our physicians, most hours of the day and into the night. And that was really starting to catch on. But then as soon as COVID hit, within about a week, we had to get to almost 100% virtual. So in behavioral health, for example, we went from about 5 to 10% virtual to 90% just overnight, and really saw similar trends throughout all of our organization, primary care and specialty care. And so really, it allowed us to change the behaviors, the biases, the perceptions, not only for our physicians and healthcare teams, but for our members, because you had to get healthcare that way. People really were sort of forced to try it, and I think really liked it. And so, as we've gotten further away from the beginning of COVID, at least we're certainly still in the middle of COVID, we've realized that we're probably settling out somewhere closer to 40 or 50%. A lot of people that hadn't been in to see the doctor for quite some time face-to-face did want to come back in, but a lot still really want to continue that virtual care. So I would say in mental health and behavioral health, for example, we used to have about 30% of our patients miss their psychiatry appointments. And there was sort of that stigma of coming into the doctor's office. And, there's a lot of that stigma that we all know has been around for many years in terms of psychiatric care. And all of a sudden, we're doing this virtual care and that stigma is gone. So We don't have the no-shows anymore. People are actually coming almost 100% for their visits. And so they're getting that really well-deserved and much needed care that maybe they weren't before. So it's really propelled us forward and allowed us to take better care of patients in many cases and really to meet our patients where they're at. So to me, it's been really exciting. I think we've moved faster in weeks and months than maybe we would have otherwise in years.
Dr. Orser, if you could talk a little bit about, you have a safety net clinic system and maybe a slightly different group of patients, maybe different access to technology. Wondering how you have handled it, what was going on before COVID started, and whether you were able to push people toward new technology quickly, like as other systems have.
Definitely. So because we're a safety net clinic, we're a community health center, our large payer mix is from Medicaid and Medicare. And at the time prior to COVID, they didn't reimburse for telehealth visits. And so we had not really implemented telehealth prior to COVID in any way, shape, or form. We had this 2-year horizon that we thought maybe we'd be able to lobby CMS and be able to get it reimbursed. And then suddenly, overnight, CMS was paying for it. And within a week, we had worked with a platform, we had deployed hardware, we'd increased our own infrastructure so that we could have the bandwidth to be able to do telehealth. And we were able to do the same for our patients. And so really pushing them along, getting them involved in telehealth. We still had some problems. We serve a very rural and frontier area out in the Eastern Plains, and they simply didn't have the infrastructure to be able to do telehealth visits. But we were able to do telephone visits with them, which was a huge thing for our patients in the rural areas that didn't have the internet, but also some of our inner city patients who didn't have the minutes to be able to do a telehealth visit, didn't have a safe place where they could have a video visit. And the other thing that we were able to do with telehealth was connect our patients with their specialists in the city. And so a lot of our patients would have to drive up to Denver or over to Denver to be able to see their specialists. And now they were able to come to our clinic, use our internet, and be able to have that interplay with their specialists without actually having to drive for an extended distance to be able to do that.
For somebody who's connecting on the phone, maybe hard to put a percentage on it, but what portion of sort of a real quote unquote doctor's visit or provider visit do you think they were able to get? And does that change as you get better at it and as they get more used to it?
You know, it certainly was difficult at first, not being able to see the patient. And it was hard for providers to really get used to that because we've all been trained. You've got to touch the patient. You've got to listen to the heart and the lungs. You've got to look in the ears and the mouth and to be able to really figure out what's going on with a patient. But with time, we realized there are things that you can find out over the phone. Is the patient short of breath? You can tell that just by their speech patterns and the way that they're talking to you. The other thing is that we realized there are certain visits that really lend themselves to telephone visits, right? So lab follow-ups. You don't necessarily have to see the patient face to face to be able to talk about their labs and go over the treatment plan. And so really figuring out what's going to work well over the telephone and what we're just going to need to see a face to face for.
Sharif, with Denver Health, what have you seen? What were you able to do before COVID? Your inpatient experience, and I assume that you were working on many things before COVID came along. But tell us what it looked like before, and then, as everyone has said, how you crammed 20 years worth of work into 18 months.
Thank you. Yes, I mean, I agree a lot with Dr. Orser. For us, we have a primarily Medicaid and Medicare patient base. So the fact that it was reimbursed, again, propelled us to be able to do this work that we hadn't been doing. You know, a lot of our patients are working class individuals who might have struggled to find childcare or transportation to appointments. So in a lot of ways, having the telehealth options created greater access to care for a lot of our patients and being able to get there. I think one of the things that has been really important is how do you create an authenticity around these appointments and a sense of connection between the patients and the providers. You know, whether you're just on the phone or on the video, there are elements of a connection between a provider and their patient that can be lost in that. And so it's really required providers to think differently about how do you create that sort of compassionate environment within the technology setting. And, another example of that is if a provider is running behind, if they're in the office, somebody might be able to get up and say, hey, your provider is running a little bit behind. We'll be right with you. But if a patient's waiting for a telephone call at a specific time and it's not coming, they're starting to get anxious about that. And so I think some of that human connection we've had to figure out how to do that better through technology.
Do you have an example? Like, what can you do? Obviously, you don't want patients on bad hold music for 15 or 20 minutes while they're waiting, but can you text them? Is there enough personnel, is enough technology to let them know what's going on?
Yeah, that's been part of it, is reaching out to people through the patient portal MyChart, or having somebody call them and say, hey, your provider's running a little bit behind. I know that's what's happened with when I had a telemedicine appointment with my PCP, and I received a call right at the time where the appointment was supposed to start. And actually, sometimes what some of our providers do is they have an MA get on the phone, a medical assistant get on the phone, get you started with it, and then they'll turn you over to them. One of the things that's been really important too in these appointments for kind of creating that connection is really doing some agenda setting at the beginning of appointments and saying, and I think this has always been important, but especially when you have you don't have that face-to-face connection, you really want to try and understand what the patient is trying to accomplish in that particular appointment. And so setting that agenda has been a key part of us being able to do that.
Jeff, did you have to, Kaiser's been working on this for a while, so you've been training people, I assume your providers, all for a long time, in how to keep that relationship, improve that relationship over a chat or over a video. Did you have to train a lot more people? What has their reaction been to more providers spending more time, whether it's on chat or on video during the pandemic?
Yeah, as you said, Michael, we sort of had that infrastructure before COVID, fortunately. And, both Sharif and Adam talked about the reimbursement piece. And so for us, we're a capitated system. We started out, 52 years ago here in Colorado as an HMO. So we're paid per member per month, which means we're not paid to do more care. We're not, paid every time a member comes in. So we've already had that sort of mindset for many, many years that we can take care of a lot of things on the phone, for example, and then that turned into video and chat and email. So we've had that sort of culture already set up for many years. And so we did have to do some more training. When you're in medical school, we all learn how to address the patient and make eye contact and appropriate, other types of physical contact and things. But we never were taught, certainly when I came out of medical school 20 years ago, how do you really connect with a patient on video, for example, or even chat. And so a lot of times you think you're not going to have as much, you're not going to see as much. But there were some really pretty amazing things. And I think all of us have seen in our either professional lives or personal lives on Zoom or Teams or whatever platform we're using, you see where people are living, right? You see their homes, you see their family, you see their cats and their dogs. And so sometimes you'll see some safety hazards in the background. And so a lot of times, you see a cat run across the screen and it's a moment of levity where you can sort of laugh with the patient and then, talk to the kid about his cat. And sometimes I'm a pediatrician, that sort of calms things down a little bit, ask the cat's name. And so it also gives you some opportunity, almost like you're in their house. It almost in some ways feels like the old-fashioned house calls, but we really had to sort of retrain our physicians, really silly things about, what your background is, what the lighting is, how to really sort of stop and address the patient. Because in our world of quick texting and videoing and FaceTime, sometimes we forget about those things. So it was sort of a reminder in some aspects, and in some, it was a new training altogether.
Dr. Orser, before they get on with you, or maybe just after, they might be on other forms of social media or video, and they might be doing research in their own research into medical conditions, into COVID treatments, into COVID vaccinations. I'm wondering if you feel from the group that you see in just everyday life in medicine these days, Has that political element or that social media element crept into a lot more conversations? And do you find yourself talking to patients more about the things that they think they've discovered on their own or they want to ask you about?
Absolutely. This is something that has been going on for years, where patients will look things up. There's all sorts of websites out there that can diagnose you without ever seeing a doctor. But it's been accelerated because of COVID. And recently, I saw a patient in the exam room, and we were doing her physical exam. She's 16 years old. She'd had her first COVID vaccine. And I was talking about, why haven't you gotten your second one? You're 5 or 6 weeks out. It's time for you to go ahead and get that. And she said, no, no, no. I saw on the news that a girl got paralyzed because she had her second dose of the COVID vaccine. And I said, oh no, that's terrible. Tell me more about it. What news source did you find that on? And she said, oh, it was on Facebook. And so really talking to her about credible news sources, that you don't necessarily go to the .coms. You look for things by the CDC and various other credible sources. And if you have questions, come and talk to me about them, and try to allay her fears and really talk about where we can find credible information and how I hope that I can serve as a source of credible information for my patients.
John Ingold has written about how the people left who have not wanted to get vaccinated so far may be hard to move in that direction. And I'm just wondering if you're finding that as well.
It is, we can talk to them about all of the studies, about the mRNA technology that's been around for 20 years, about how safe and effective we know that these vaccines are. And we can talk until we're blue in the face, but because of a variety of factors, people aren't wanting to get vaccines. The early adopters have already done it, and it's very, very few and far between where we're actually able to change patients' minds at this point.
Sharif, Denver has pretty high vaccination rates. I'm wondering if these conversations come up still, though, with patients who are still reluctant. If the mask issue comes up, if you, as a patient experience person, have to talk to people about whether they feel comfortable in masks, whether employees that you work with a lot want exemptions, and how you're dealing with all that.
Yeah, the mask exemption conversation has been interesting, and now I even had an individual recently who was requesting their provider give them a COVID vaccine exemption because it was required for their work. And this particular individual was immunocompromised and had a history of asthma, and the provider tried to provide, like Dr. Orser said, all the best information, most reliable information that she could. And the patient, felt like getting the vaccine was actually more dangerous than if she was to get COVID. And she was very frustrated by it. And she reached out to my team, the patient advocate team, and was basically saying, "Can you get this doctor to give me this exemption?" And it was a difficult response to say, that's not our place to be able to do that. We really rely on our clinical care team to make the decisions that are right for their patients. And so we're having those conversations. We have conversations with folks that want mask or that have mask exemptions, and our staff are frustrated. They sometimes feel like they have to be the PPE police in the hospital, and while they're trying to take care of a lot of patients right now. And it definitely is impacting how people are interacting with one another, whether that be the patients with non-clinical staff, between our own care teams. There's folks that have been in quarantine essentially this whole time and still are really limiting their activities. And so it's hard for them to hear of people that are reluctant to get vaccinated, and then they end up in the hospital when they've taken such great effort or made such great efforts to try and protect themselves and their families.
Dr. Krawcek, Kaiser, go ahead.
I was just going to say, and I would add in, we try to approach all of those conversations, again, with a sense of compassion and empathy and understanding, because, being cruel to those folks is certainly not going to get us anywhere. And so it's a really delicate balance.
Thanks, Dr. Krawcek. Kaiser has been a strong supporter of vaccination throughout the pandemic, as long as it's been available, and continues to be. How do you keep staff from getting that kind of frustration that Sharif is talking about, and compassion, and continuing on the persuasion mode as opposed to the argumentative mode?
Yeah, that's a really great question. I had an employee email me a week or two ago and say we had put up one of our physicians' quotes saying that she was really struggling with compassion fatigue. And this employee said, physicians don't get to have compassion fatigue. Isn't that what you went to medical school for? And I was up at our Greeley and Loveland clinics yesterday talking to the doctors, and you really see how it is affecting them. And I feel that in the exam room, but certainly I think our adult providers, our internal medicine, family medicine providers feel that even more with these really high risk patients that they're seeing day in and day out. And, one of the docs I was talking to yesterday said, there's these patients that I've had relationships with for years that all of a sudden are mad at me and leaving me and giving me, bad reviews because I talked about the vaccine. And a lot of it, as Dr. Orser said, has to do with, information that they're hearing on Facebook or the internet that's not necessarily right. So it's a really tough balance because our physicians are so mission driven. They want to get that right information. And as pediatricians, we're taught throughout our entire training how to have those conversations with young families, with young kids around vaccines, right? But studies show us that those families make their decisions on vaccine before they get to the pediatrician. They're making, for the most part, those decisions when during the pregnancy, when they're talking to their OB-GYN. And I think similarly, a lot of people that are still left not vaccinated, they're coming in already with very, very strong beliefs around not being vaccinated. So we do a lot of education for our physicians and our healthcare teams at Kaiser Permanente to really educate them and give them the tools to have these difficult conversations. And you never want to get into one of these sort of us versus you conversations because that just turns people off. We all know that. And so, it's really about building trust. And Sharif, as you said, it's about empathy. As you really sort of sit down and listen to some of these folks and try to understand where they're coming from, it's really heartbreaking. Because they're making really, really tough decisions not to get a vaccine that not only puts their health and their life at risk in many cases, but their profession, their job, their ability to earn. So I do have tremendous empathy. And I think it's really important that we all remember, even though we've been dealing this for a year and a half now, and it's really tough, we just have to continue to be curious and empathetic and really be there to care for those patients.
Dr. Orser, do you find you or your staff feeling compassion fatigue, finding it hard to get up the next morning again and have some of the same conversations?
Definitely. Burnout among physicians and advanced practice providers has been an issue for a long time, and that has been exacerbated significantly over the past 18 months. And we have been really working to find ways to ignite the spark again in our providers and giving them opportunities to do things that they're passionate about, whether it be participating in a walk with the doc program where they get out with patients and they walk around the grounds of their health center, or if they're really excited about obesity, starting obesity clinics where they can work with patients who have struggled with weight management. Folks who are interested in HIV, getting them involved in our HIV care clinic. And so really working with providers to know what is going to excite you and get you up in the morning and have you keep coming back. They're so valuable and they do such hard work every day. And so it's really been tough to see the strain that this has placed on folks and this compassion fatigue and just fatigue in general. So really looking for opportunities to get them excited about work again.
So tell me how that would look. Walk with a doc. You have beautiful Pikes Peak looming overhead if you guys go outside. Would that be a group situation where you might all talk about a common problem that people have with a provider amongst them? Or what kind of situation does that work for?
Yep, it works for all types of situations. And we've done it with a few different clinics now. We're actually partnering with a local organization called the Trails and Open Space Coalition that's mapped out trails and parks all over the city. There are over 200 here in Colorado Springs. And so we have providers and staff volunteer, and then we sign up a bunch of patients to come and talk about it. And sometimes it's just a bunch of patients who have diabetes, and they go out and they can ask questions to their doctor, and their doctor can say, hey, tell me about what you're doing to control your diabetes. And it sparks a conversation among the patients. And then they get to have ideas that they share with each other. It might be pediatrics, and this is a safe place where you can come and it's close to your neighborhood. These are the things that you want to look for as you cross the street, and teaching just basic safety principles. And so that's been a program that's been really exciting.
Sharif, if we could talk a little bit about mental health. We have a question from a reader wondering where you direct people who are looking for good mental health information, whether it's within the Denver health system or whether it's something online where they can get some help. Does Denver Health have a lot of resources through the personal chart and personal portal information where people can go that would give them some things if they're not short of actually seeing the provider every time, that might help them keep up on things that would make their world feel better?
Denver Health has a lot of behavioral health services and recognizes the need for that. I think one of the big challenges around behavioral health services is the lack of resources that are allocated just in general to be able to provide those services. One example of the way that we're really trying to create what we're calling a no wrong door approach is through our Center for Addiction Medicine, which was started about a year and a half or 2 years ago. And the idea is that anybody can access any of our addiction medicine resources through any entryway. So if somebody came into our emergency department and wanted to get treatment, that they could get a referral there. If somebody came into their primary care provider, that the referral can come there, that they can reach out directly to one of our outpatient behavioral health clinics. And so I think with there being a lack of allocation of resources in general, what you have to do is you have to make the resources that are there as accessible as possible. And I think that's really what we're trying to do, is to make sure that all of our providers are well trained on knowing what resources are available and how to access them so that they can point the patients in the right direction. So whoever they come to can get them to where they need to be.
Are Denver Health patients more worried about their kids and how they are getting the help they need, and having been out of school, now they're back, but for a long time they're out of school and missing those resources? Do you feel that there's a big demand for that kind of pediatric, either mental health care or physical care?
Yeah. Our adolescent psych unit is pretty full these days, and we're seeing a huge crisis with mental health, especially for the adolescent population. And I don't think it's necessarily Denver Health patients that this is limited to. I think it really is a societal thing. And it's a major issue right now, the needs for kids and mental health.
Jeff, Jennifer Brown has been writing for us about the lack of access for adolescents to mental health care, emergency psychiatric care, and that kind of emergency facility. How does Kaiser handle that? Are you looking for more space? Is that a big need throughout the Front Range?
Yeah, I think I know it's a big need throughout the entire country, actually. So there's a few reasons for that. Number one, there are significant shortages in all kinds of mental health, behavioral health providers. So psychiatrists, therapists, nurses, through every part of the country, including Colorado. So that's one issue. And then two is increasing demand. Certainly with COVID and people being, in their homes without, a lot of outside contact, that's contributing to it. COVID itself may be contributing to more mental health disease in terms of the impact on the brain. We'll learn more about that as time goes on. And I talked earlier about the stigma associated with receiving mental health and behavioral health care. And as that stigma is decreasing over the last couple generations, people that weren't getting care before now are coming to get care, which is actually a good thing, but it doesn't help the supply and demand imbalance that we have. And so there's a few things that we're doing. I think One, in the most significant, I think, from my standpoint as a pediatrician, is we have behavioral medical specialists, BMS as we call them, who work right in our primary care clinic. So we screen all the kids, all the adolescents, certainly for anxiety and depression. And whether it's through screening or they're coming in to talk to me about these things, as soon as I identify a child or an adolescent that needs that care, I can go across the hall and grab our BMS who can come and immediately have that care with them. So we don't necessarily have to send them to a psychiatrist or a therapist, but for those levels of care that are a little lower, we can help them right away and hopefully prevent these things from turning into more serious things. So that's one way. Two, as you were talking about with Sharif here, that piece about information and understanding the resources that we have in our community is really important. So we have social workers that help with that. And we're working on an opportunity right now to offer people, as part of their insurance with us, free text coaching for sort of that more mild distress. So again, if we can catch things really early and progress, hopefully they don't progress into the worsening things. But I think we all heard a couple of months ago, Children's Hospital declared that we were in a crisis state in terms of adolescent mental health and suicides. And I'm sure, Dr. Orser, you're seeing this, but we see this over and over. And over the last year and a half, it's just gotten more and more of an issue. So, we send those patients that are more high acuity patients to many different sites, but sometimes it's hard to get the beds for them because we don't have the beds in the state. So we're continuing to work on that. But, just like we always say with preventative care, that's the way to go. And if we can catch things really early and prevent them from getting worse, we won't need as many beds in the future, particularly with our supply and demand gap that we have.
So our audience is asking, again, a little more specifically, what news sources do any of you, question could be for any of you three, what news sources do you look at for mental health reporting? This may be more specialized than they would look at for themselves, but do you feel that there are people, organizations that are doing a good job with mental health reporting, keeping up on that field that we can point them to? Nothing's coming to mind specifically. You all think about that, and I'll go on to Dr. Orser. I was going to ask about this idea of the warm handoff, they call it, of someone, you're in an exam room, you're coming in for a physical problem, but it's clear from screening and talking to your provider that you have some behavioral health or mental health issues that you'd like to talk about. And there's someone right there. And safety net clinics have done a great job trying to do that integrated care as often as possible. I'm wondering if you feel that Peak Vista has been able to keep up with that in terms of equity and making sure that a lot of your patients have access to that kind of integrated care.
We do. We very much believe in the integrated model. As providers, as medical providers, I'm not sure what we would do without our behavioral health providers right there next to us all day, every day, because they play such an integral part in the health of the patient. And so just like Jeff was saying, we have patients who pop positive on the PHQ screener for depression, or just patients that when you walk in the room, something's not right. And so getting our behavioral health providers involved right there and not missing the opportunity. Sometimes what will happen is you do a referral out somewhere and then they get the wrong phone number, or they can never actually get somebody on the other line. And so they never make it out to the referral, and they never get connected with a behavioral health provider within the community. And so having somebody right there who can work with them for several sessions. And then if they need additional care, we also now have a freestanding behavioral health center at Peak Vista, where we have psychiatric nurse practitioners, a psychologist, as well as therapists who can do long-term therapy and then address the medication needs. And the other great thing that's happening in Colorado is that there's a series that the state offers for free for primary care providers to learn about pediatric, adolescent, and adult psychiatric cases, learn how to treat them within the primary care setting so that they're more familiar with the diagnoses and the treatment options so they can take care of those options right there in the primary care medical home.
And I assume that you have also tried to integrate other forms of care. A lot of clinics are trying to integrate dental health care. In addition to that, it's hard to do that virtually. How have you been able to do that in the past year and a half?
So we do have dental in many of our clinics integrated within our medical centers. Of course, as you said, that's really hard to do virtually. And so a lot of those patients get screened, and then they do have to set up an actual physical appointment for their dental care. But the other thing that we also have is we have social health experts. There are care coordination and care manager specialists. And so they work through a lot of the social issues that affect the physical and mental and dental health of our patients, knowing that it's all interconnected. And if we don't have people to address those things, their medical health is never going to get better. Their mental health is never going to get better because we're not addressing those social things that are having such an impact on their health.
Sharif, I was hoping you'd talk a little bit more, and I think Jeff wants to too, about social determinants of health and how that affects your patients and what you try to provide for people. One of the things we talked about from a diversity and equity standpoint was languages alone. It's not just Spanish that we need to think about in Colorado. Tell me, how many languages do you deal with at Denver Health in a given year? I think it's a pretty amazing number.
Yeah, and actually, happy International Translation Day to every day. It's a UN recognized day where we honor the language professionals throughout the world, and that includes medical interpreters. Here at Denver Health, we have a nice, very large language services team by comparison to many other places. We have 20 in-house interpreters, and we last year had over 400,000 encounters with patients, limited English proficiency patients in over 120 different languages and dialects. And what we're seeing is really interesting right now is that we, throughout all of 2020, about 85% of our non-English encounters were with Spanish patients, and then 15% divided between those, other 120 plus. We're actually seeing a decrease in the number of Spanish encounters. We're at about 80% of our non-English encounters, and an increase in the diversity of all the other languages. And one of the really, I think, exciting things that is happening right now is as we're welcoming Afghan refugees into our Colorado community, a lot of those folks are coming to our Lowry. We have a refugee clinic there. And so we're really trying to gear up our language services in Pashto and Farsi, those languages. And so one of the things you really have to do is you have to be aware of what's happening in the community and recognize the language needs that are changing and fluctuating because of what's happening in the community. And it's crucial that we provide healthcare in the preferred language of our patients. And there are major care concerns when that doesn't happen. I always tell somebody, imagine being in another country and somebody is and you're in the hospital and don't understand the language, and what that would be like, or somebody trying to, the importance of using qualified and well-trained interpreters. People speaking in broken Spanish is not the answer, right? We call it Cancun Spanish. Sometimes we think that we may know enough to be able to communicate our point, but it can have really detrimental effects on a patient.
Jeff, you have 600,000 plus members, so you encompass quite a broad range of people, quite a broad range of diversity in patients for sure. What have you been able to do from the provider standpoint to make sure that you're broadening diversity among the providers, making sure that you have people that can make that connection if that's what people are looking for? Jeff, if you could go off mute. Looks like you're still on mute.
Sorry about that. I had to sneeze and I went on mute there.
Yeah.
So equity and inclusion and diversity has been a part of our DNA since our inception. And I think over the last year after the death of, George Floyd, we've even put more of an emphasis on it, both for our patients and our employees and physicians. And so I think, I would agree with everything that you just said, Sharif. In addition, we know that when, the physician looks like the patient, there are better health outcomes, right? And we don't have a lot of diversity in our physicians in this state in general compared to other states. And so one thing that we're really working hard is going outside of Colorado to recruit physicians of color and more diverse physicians in. And really our goal is that our medical group looks like our patient population, right? So we hear, particularly in mental health, actually, from Black, African American, and Latinx patients that they want to see a Black or a brown therapist or psychiatrist. And we've really struggled with that, frankly. So we're really doubling down on our efforts to bring in physicians of color, because we know we have better outcomes there. We're really working hard to educate all of our employees and physicians around, biases, equity and inclusion and diversity, cultural sensitivity, all those things, because we know it increases and improves outcomes. And then the other thing that I would say is we have to think about improving healthcare disparities in systems, right? So the first thing you have to do is to be able to identify, people's race, ethnicity, language preference, sexual orientation, gender identity. That's step one. And then step two is to have those systems to look at the outcomes, right? So to look at hemoglobin A1C levels for folks with diabetes, or blood pressure readings for people with high blood pressure. And we know that our patients of color have worsening rates often. And so our goal really is to close those care gaps, we call them, right? And so you do focus on specific patients and specific populations to really try to improve the health of those communities and those populations. And then the last thing that I would say is, over the last year and a half, we have formed a physician and professional staff diversity council. And these are folks that really have an interest in, on their own time, are going out into communities and trying to help with the vaccine hesitancy, with diabetes control. And, it's really making a difference. And what's really great for me is to see these physicians, these staff who have this passion for our community, and often people in our community who are forgotten or underserved, to really go out on their own time and volunteer to make their lives even better. So I think it's all about a systems approach, and it's not just from healthcare, right? I think our safety net, as Dr. Orser was saying, all those things that, where a patient lives and the social determinants, those things are so important in one's total health.
Dr. Orser, we also need geographic diversity, and we need providers who are willing to practice in a lot of different places. You're a rare bird, if I remember correctly, in terms of growing up and training in Colorado, and now you're practicing in Colorado. And I'm wondering how have you been able to get providers to go, all the way out to the border on the Eastern Plains? That's been difficult in a lot of communities to try to get people to serve. And I'm just wondering if you found any tricks, any ways to make that more successful.
Sure. So one of the ways that we've had the most success is by hiring providers from the communities that they serve. And so right now we have an opening in Lyman. A lot of people have never even heard of Lyman, other than it's a truck stop on I-70. And so getting somebody from another state to come in and work there is really tough. Getting somebody even from within Colorado. But if we can work with a community and work with people who are trained and hire those people into the positions, then it's a win-win for everybody, because the community already trusts those people because they know them. And then you've got better healthcare because you've got that trust between the provider and the patient. The other thing is that the School of Medicine also has a rural track. And so getting students who are already excited about rural medicine, having them learn to rural medicine throughout their entire training, and then working with them to get them positions in rural places is really helping with our workforce shortage in the rural areas.
And UC Colorado Springs has a nursing program, if I'm right. And have you been able to connect with people for that?
We do. And they also have, so we at Peak Vista, we have a nurse practitioner fellowship program. And we actually try to look for nurses within our own program who are going through a nurse practitioner program to be able to hire them on, teach them more through the fellowship, and then have them be providers here at Peak Vista.
great. We have a reader question about, and please, if people have more questions, please include them in the Q&A at the bottom, and we'll make sure we get them, as many of them as possible, before we're done at 7. So there's a few minutes left. Jeff, I wanted to talk to you about all the technology available and the statistics and the numbers crunching available in a big system like Kaiser. One of the promises of getting everybody on electronic records, on preventive medicine, and on video and telehealth was to prevent unnecessary ER visits that are very expensive, to prevent extraordinary care before it's necessary, and to do preventive care instead. And I'm wondering if you have found in your experience that that is working, that you are able to lower the cost of care or just provide more appropriate care, or if people just end up using the doctor a lot more often if they know they can chat with you at almost any time.
Yeah, great question, Michael. I think it's a combination of both. And so we know absolutely that integrated care, care where you're not incented to do more care, but you're incented to do the right care, and care that's connected by an electronic health record, those things all decrease the cost of care. So when I started out as a pediatrician, 20 plus years ago, we had paper records, right? The old paper charts that many of us remember from being kids. And often a patient would come in and say, I was just at the emergency room and had some tests done, or I was at another urgent care, or, and we couldn't get those results. So inevitably you'd have to repeat some of those. And so that right there saves money, because right now, and not just within Kaiser Permanente, we're on Epic electronic health record. And so anybody else who's on Epic, we can see right into their record, and we can see those labs. So that not only saves money, but it's more convenient for our patients. Sometimes we can just connect with them over the phone for those things. And we know with our chat with the doc, for example, that I talked about earlier, we have really great data to show it decreases the cost of care. For every chat we do, we save the patient about $90 of care that would otherwise happen downstream. We save, and that's on average. So sometimes it's much higher. We save urgent care visits, we save emergency visits. And again, there's cost associated with that. And there's, the patient doesn't have to go to the emergency room, because often the patient doesn't know where to go. They just know that they need or want care. And we can really help with that navigation. So I think that part's really important. In terms of your question around sometimes are they just seeking more care, about 10 years ago at Kaiser Permanente, we started using email, and we don't charge for email. And what we thought at the time was, as email increased, that we'd see that decrease in face-to-face patient volume, and that has not happened. And in fact, over the years, just since last year, emails have increased by about 100%. And when they used to be pretty small, a sentence or two, and sometimes now, it'll be paragraph after paragraph and 3 emails, because they get limited to 400 words. And so what we've seen there is it's not replaced the old and other visits, but it's actually been additive. And when Dr. Orser talked about physician burnout, what's happening, especially for primary care physicians across this country, is we're putting more and more on their plate. And that just means that they have less time to spend with us as patients, right? And so we really need to get to a place where we're finding the right care for that patient at the right time. Sometimes it's email, sometimes it's chat. So if you're going to do email and a chat and they're going to come in anyway, you might as well just have them come in face to face for the first time. And so I think that's really going to be the next frontier of medicine. And a lot of that may be done digitally. And sometimes people think, oh, well, then if we do that digitally and we use computers and automation and everything, I'm not going to have that personal touch. I really think as physicians, that actually will give us more time to spend with patients, that face-to-face patient-physician experience that we all went to medical school with. And as patients, you really appreciate.
Sharif, Denver Health has tried different elements over the years in terms of triage and not having people waiting in the ER if that's not where they need to be. I'm wondering, as someone who works on patient experience, do you find that you have had success steering people to the kind of care, the level of care that is really right for them? Or do people resent it? Do they say, look, I came here to the ER for a reason. I don't want you steering me somewhere else. I don't want to just talk to someone on the phone later. How has that worked out?
Yeah, it's really interesting, this idea that Jeff mentioned of helping patients understand where the best place to seek care is. We started a virtual urgent care program during the pandemic, and it's been very successful. But I think sometimes people are trying to get care via their messaging with their doctors, or a virtual urgent care visit that needs to happen maybe in an emergency department or an actual office visit. And I think that there's probably a mix of folks that are frustrated when we say, that's something we'd really like for you to come in to talk to us about. It's interesting. Our adult urgent care center used to be connected to our emergency department before we opened up our new outpatient medical center. And patients would come in and they would say, I'm here for an urgent care visit. But once they were triaged at that desk, it's like, this is not actually an urgent care visit. This is a level of care that's needed in the ED, and a patient would end up in the ED, and they were frustrated because they came for an urgent care, but now they're in the emergency department, and now they're going to get an emergency department bill. So I thought, okay, it's going to be great when we move our urgent care over to the new building. They're completely separated. People know that that's happening. But now people go to the urgent care and they need a higher level of care. And so now we've got to get them over to the ED. And our urgent care that's right across the street is like any other urgent care, freestanding urgent care in the city, that we've got to actually transfer that patient over to the ED. So I think it is challenging when you have all these different ways that you can access care to really help people to understand what's the right place for this particular need. Whether dispatch health is an example of home health visits that I've actually used them when I had a cold or a flu or something, and they just come right to your house and take great care of you. And we have a nurse line program where people can call in, and that's actually what I think is probably one of the most effective ways for us to be able to communicate to patients where they should seek care, is through that nurse line program. They can call, they can speak to a nurse or a doctor about what's going on, and that person can do some triage there to say, this is something you might want to go into the ED for right now, or you may just need to follow up with your PCP. So I think it's incumbent on us as a healthcare system to help our patients to understand where the best place to receive their care is.
Before we run out of time, I did want to get back to the technology question and ask each of you what you see coming, whether it's something that you're looking forward to or something you're dreading. Is there a technology that you're using yourself, that your family is using yourself, whether it's a dispatch health system? Are you wearing a smartwatch? Do you care exactly how many hours of sleep you're getting a night? Do you care how many steps your family walked? Do you care about that for your patients? Do you encourage them to use it? So Dr. Orser, I'm wondering, is there a technology change that's already here or on its way that you would either encourage people to use or tell them to steer away from?
Sure. So I think remote patient monitoring is certainly the wave of the future. To be able to get accurate data on vital signs is really important. And oftentimes when a patient comes into the office, they're nervous, and we even call it white coat hypertension, because people's blood pressures shoot up just thinking that they have to see the doctor. And so we don't always know what their accurate blood pressure is. And so being able to monitor them in their own home, in a regular setting, then we're much more able to get better data from that. And so just last week, we started talking about, are we going to accept data from Fitbits and Apple Watches? And is that something that we feel confident in? And being able to develop interfaces where that information can drop directly into our electronic health record. And we think that's where we're going to go. We just want to make sure that we've got valid data, and then it's going to work out for us.
Jeff, is Kaiser going to accept Fitbit data into its system as a way to look at the overall picture of a patient?
I think that's definitely the future, and we're already doing, as I said, blood pressure checking and diabetes and those things. So we'll continue to move forward. Right now, we're doing that with more high-risk patients, so high-risk pregnancies and patients that already have very high blood pressure. But my guess is in the future, we'll be offering that for everybody. As I said, I was just up at our Loveland medical office building yesterday, and I was shadowing one of our internal medicine physicians, and a patient came in, and she was, she was sitting on her couch a couple days beforehand, and all of a sudden her heart started going really fast, and she came in to see, what that was. And she had her Apple Watch on, and the doctor said, well, what did your Apple Watch say? And she said, well, the heart rate was 120 and I didn't have AFib. So right there, that really narrows down the diagnosis for the physician. And there's a lot of tests that didn't have to be done because we knew that. Otherwise people come in and say, my heart rate was going really fast. Well, were you able to take your pulse? No, I don't know how. It was probably like 200 or 300. So I think even in that case, that's happening today, and that's not necessarily coming into our system, but in real time, you can see how it's changing the physician's decision-making and really making it a better visit for that patient.
So that's the positive thing, but does that mean that you're also getting at midnight a lot of phone calls from people saying, my watch just went off, I'm at 120 or 130, and you say, well, what are you watching on TV? It turns out they're watching a horror movie. Or, are you getting more contact than you want in some cases?
We haven't seen a lot of that. I think there's been a few cases of that, and that's really where that digital or that on-demand care tends to really be helpful, right? Because you can chat in, and the doctor is there at 3 a.m. or on video, and they're ready for that sort of short visit. So you don't necessarily have to make an appointment and take off of work and come in, but you can do it right when you need. And for the doctors, for the nurses, typically that's a pretty easy answer. And so it's a little different when we start to think about these things in the digital era.
Sharif, is there a technology that you use yourself, or do you feel like there are ways that you can get Denver Health patients to start using that smartphone that they're often looking at for good research or good information, as opposed to the negative?
Yeah, from a patient experience perspective, I think one of the things that I'm excited about for the future of healthcare is I think for a long time we have shied away from thinking of patients as consumers, and I think that has prevented us from being able to drive improvement as quickly as a non-healthcare industry. And I think my favorite technology is the MyChart patient portal that's available through our Epic electronic medical system. And I don't know about you all, but if a company doesn't have a good app these days, I tend not to use that company. And I'm finding that having an app to be able to look at my labs, to be able to review radiology reports, to be able, again, to communicate with my doctor, to pay my bill. I think that app and these sort of patient portals that exist are helping us to move in the direction of really providing that level of customer service that has been lacking from healthcare for maybe some time. And so that's my absolute favorite technology right now is the patient portals that are available through electronic medical records.
So before we go, let's do a lightning round to try to leave people on an optimistic note. Dr. Orser, asking all of you, what do you feel optimistic about with COVID in particular, whether it's vaccinations or where we're going, research? Is there reason for us to be optimistic in Colorado about where COVID is going?
Yes, I am thrilled that the medical and scientific community was able to come together and develop a vaccine as quickly as they did, that the vaccines are as effective and safe as they are. We would have been happy with 50% efficacy, and we're up closer to 90% at this point. And that to me is thrilling. We just have to get people to actually take the vaccine.
Sharif, what makes you optimistic, or what are you thinking about COVID at Denver Health?
I think we've learned new. I've been really proud to work at Denver Health as a public health institution for over 160 years. I think it's helped us to weather the storm better than a lot of other places because we have a lot of great subject matter expertise around public health issues, and I think I'm optimistic about the ways that it has forced us to think differently about how we provide care to our patients.
Dr. Krawcek, what are you thinking about COVID?
So two things. I think number one, it's been the innovation that we started off talking about tonight. So we've seen this amazing innovation from our frontline physicians. They are seeing firsthand, day in and day out, what our patients need, and they're coming up with better and better answers to help them. So that's number one. And then number two is our community, right? And so how do we not only help each patient in the exam room, but we've been able to really help our communities and in terms of communication and education. And that's really been important. I think as we've heard a few times, you have to think about the community as a whole. If you're going to improve total health, it just can't be the problem the patient is coming to you in the exam room. So community and innovation, I would say.
Well, thank you very much to all of our panelists tonight. We're going to wrap it up and make sure we respect people's time and your time. Dr. Orser, thank you very much. Dr. Krawcek from Kaiser, thank you so much. And thank you to Kaiser for sponsoring this event tonight. Sharif, thank you from Denver Health's perspective. And thank you to all the audience members who stuck with us and helped make this event possible. We also just want to give you one plug to take a look at the new health and environment newsletter that we've started called The Temperature. And you can sign up for that at coloradosun.com/temperature. So thanks again to everybody and good night. Appreciate you all reading the Sun.